Dushantha, what do you think about the portable machines? Are they available for our patients in Sri Lanka?
Yeah, so private sector it is available roughly between 2 and 4 lakhs in Sri Lankan rupee. Now in the public sector, patients should be actually referred to the respiratory physician. I told you that we have to properly assess the patient. We are going through the patient, examining, come to the specific diagnosis, blood gases, lung function. We verify the suitability of them to have domiciliary oxygen. Then we are giving. We are giving free of charge.
At the moment, we are using the oxygen tanks, or are we using the concentrators?
We are giving the oxygen concentrators. It is available in the Ministry of Health. Currently, Valisara, Kandy and Colombo we are giving, and we want to spread almost all the respiratory units in the country where the respiratory physicians are practiced. But this patient has to be, just because someone asking for oxygen, I cannot give, I have to assess the patient. And then I told you the assessment is not just by doing the pulse oximetry, go to the total patient assessment. And at the same time, patients should be able to adhere to what we are giving, so that we have to discuss it, adhere and explain them. And at the same time, the protection. When you use the oxygen, you know that it can burn, so they cannot smoke. There are clear guidelines for these things. We have to adhere and give it. It's actually luxury. How it comes, the oxygen concentrate, NIV for the lot, yeah, because of COVID season, it was stored in one of the warehouse of the Ministry of Health. And our people got to know, and finally after several discussions, we could be able to get the concentrator for the benefit of our patients. It's actually luxury. What our biggest problem is how we give them oxygen. If your lungs are not working, how do you going to get oxygen?
Thank you very much, Dushantha. In the absence of any further questions, we will now conclude, and there is a small appreciation from the College of Physicians for your lecture.
It's my pleasant task to invite our next speaker, Dr. Neranjan Dissanayake, who is the current president of Sri Lanka College of Pulmonologists and consultant respiratory physician, teaching hospital, Kalutara.
Thank you, Vatsala, for that kind introduction. And I'm actually standing in for Dr. Deepak Talva, who is supposed to come here to deliver this lecture. A great speaker and a good friend of the respiratory community of Sri Lanka, but unfortunately he couldn't make it, so I'm standing in. I hope that I'll be able to do justice for him. So, So when we look at asthma, and it's basically, we might think that it's a very simple disease, which is characterized by airway hyperresponsiveness. And this airway hyperresponsiveness will give rise to variable airway obstruction due to bronchoconstriction, mucosal edema, and the secretion of mucus. And it is usually reversible. So this is a very simple mechanism which causes a significant disease, a significant morbidity and mortality in our communities. Because asthma is not as simple as it seems. Hence my photograph there, which multiple phases. So the asthma that we see have multiple phases. We call the heterogeneity of asthma because asthma is not a simple disease. It has many mechanisms, many presentations. And if you look at the clinical presentations of asthma, we know that the variable airway hyperresponsiveness will give rise to cough, wheezing, chest tightness, and shortness of breath. But even that clinical presentation might be complicated. Some people might come with a single symptom, and some people might come with multiple symptoms. And in the timeline of this chronic disease, some people might have different symptoms in the different timelines. And at the same time, some of these patients will respond to simple corticosteroids. Some people might not. Some people might respond to other therapies, including some antibiotics like azithromycin, leukotriene inhibitors, and long-acting muscarinic antagonists, since the response to treatment also is significantly variable in asthmatic patients. And the reason is that even though we call it asthma, asthma is probably a syndrome which has many, many phases. When it is early onset, it is more towards associated with atopy, and it is corticosteroid responsive. And when it is late onset, sometimes these asthmatic phenotypes are very difficult to control with oral corticosteroids. It might be eosinophilic, it might be neutrophilic. One specific asthmatic phenotype is the obesity-associated asthma, especially arising in females around 40 years of age. And the symptoms, as we suggested, are variable. Some people will have exacerbations despite having treatments, and some people have, even though we call asthma as a variable air disease, where you can have reversible airway dysfunction, where you can have normal airway caliber, but sometimes you might have fixed airway obstruction as well. So it affects the lung functions as well. So why disease is that now there are recent advances, especially during the last 20 years, mainly during the last 5 to 10 years, where we have tried to identify these significant changes or differences in asthma presentation and tried to lump them into certain groups so that we would be able to better identify asthma. So by that, we are now going into personalized treatment, where we are targeting specific areas of asthma. So one such area that we are targeting treatment is severe eosinophilic asthma. And I would like, I love to do this presentation because it will help me to explain to you and discuss with you the diversity of asthma, and at the same time, the development of asthma treatment that has occurred in the world during the past decade, where now we know that all doesn't fit in the same person. So we are now personalizing medicine to the molecular levels. So we will be discussing about what severe asthma is and what severe eosinophilic asthma is, and then what are the management strategies that we have developed for severe eosinophilic asthma. So to do that, I think it is very important to have the nomenclature clear. So we have uncontrolled asthma, which is basically defined as poor symptom control, which can be assessed by the asthma control tests. And then and the other thing is, or else we can have frequent exacerbations or serious exacerbations. And some guidelines suggest persistent airflow limitation as well. So the important thing in this uncontrolled asthma is this patient can have even mild asthma, which is probably not properly treated and hence can have uncontrolled asthma. This patient doesn't need to have severe asthma per se. So the best example is asthmatic patients are given only salbutamol inhalers. Even when they have mild persistent asthma or mild intermittent asthma, these patients might become uncontrolled and they might have poor symptom control. They can have poor exacerbations, and sometimes they can have near fatal exacerbations as well. So that means we have not done our part properly. So, but even then, when we treat these patients with the appropriate inhaler containing a corticosteroid and going up to the medium and high doses of LABA-LAMA combinations, or when we don't have that opportunity, when the patient is still not controlled, when the patient is started on oral corticosteroids about more than 50% of the time during the last year, but yet still we don't control the symptoms, or else whenever we try to reduce the inhaler or the treatment, then the patient is exacerbating, we call it difficult to treat asthma. This is actually not difficult patients with asthma, or this is difficult to treat patients with asthma. Hence we come into severe disease. So in severe disease, we have already identified these patients. We have given these patients medium to high dose of corticosteroids, GNF step 4 and step 5, but yet these patients are not controlled. But one of the two important things that we have to exclude before we label severe asthma is that these patients should adhere to the treatment. And you and I know that, how patients don't take their treatment regularly. And the other thing is, the most important thing is we have to exclude certain comorbidities and optimize these comorbidities and other differential diagnoses before we label as severe asthma. So pure and simple severe asthma is actually a disease of the airway where we find it difficult to control with step 4 and step 5 GINA steps, that is medium to high dose corticosteroids and LABA combination. So simply, I think it is the most important thing that we have to know. So whenever the patient is having symptoms, the most important thing is to exclude the comorbidities. We have, especially in young patients, we have dysfunctional breathing, vocal cord dysfunction, and in Sri Lankan context, we have to be specifically careful about bronchiectasis. And then, if we know that, if we decide that this is not due to something else, but this is purely due to asthma, adherence to treatment, inhaler technique should be assessed. And if it is there, then it is difficult to control asthma. But after controlling that, if the patient has persistent symptoms, then this is severe asthma. So identifying severe asthma phenotype is very important. And when you look at the proportions, about 24% of the patients with asthma will have high intensity treatment, out of which 17% will have difficult to treat asthma. But when the adherence and the inhaler technique is corrected, only 4% to 5% will have what we call severe asthma. But this 5% will consume most of the facilities and the equipment and the time that we have for asthma patients, because it is a huge burden. We have about 5 to 10% of the patients being, having severe asthma. We know that asthma, it's affected by about 400 to 500 million people. So we have a huge amount of people who have uncontrolled severe asthma. And when it is uncontrolled, we have a great impact of the quality of life, and they have more exacerbations, and there is a large amount of patients that are there. But still we don't, even if we identify severe asthma, sometimes we might not be able to properly control them. Hence, we try to lump them into groups to try to identify who these patients are. Because when we don't understand and if the diversity of the asthma, we try to get them into lumps. And that is why in the severe asthma research program that they have tried to get them into lumps depending on the FEV1 as well as the age of onset. And then they have tried to identify clusters of asthma. And then these clusters, depending on the patient who is having atopy, is we know that allergic sensitization to a significant antigen, or whether this patient is having non-atopic asthma, and whether this patient is having moderate, severe airway obstruction. We can define them into certain lumps, and we have tried to do that. And in certain groups of these lumps, there is an element of eosinophilic asthma, which we will be discussing. And when we analyze these subsets, one important aspect that we have found in the eosinophilic asthma group is aspirin-sensitive respiratory diseases, or aspirin-exacerbated respiratory diseases, which are sensitive to NSAID, and it exacerbates asthma in these patients. So GINA also tries to identify allergic asthma, non-allergic asthma, adult onset asthma, and asthma with persistent airflow, and try to do with the phenotypes. But sometimes these phenotypes doesn't help. Hence, it is very important to understand the inflammatory subtypes of asthma, specifically in the patients who are having severe asthma. So in these inflammatory subtypes of asthma, we divide into Th2 high and Th2 low, depending on the biomarkers, where we analyze the sputum to see the amount or percentage of eosinophils, which is about more than 2%. We call it a eosinophilic sputum. Bronchoalveolar lavage eosinophil count, or bronchial biopsy showing eosinophilic infiltration in the airway mucosa. FeNO, or fraction of exhaled nitric oxide, which is an explanation of outcome of the inducible nitric oxide that is there in the airway, is also a marker of severe asthma. Blood eosinophils, obviously, when it is more than 300, according to some studies and in some biologic studies, and sometimes we can go down to even 150 in a person. When it is high, we call it eosinophilic asthma. And obviously, when the patient is having allergic sensitization, we call it atopic asthma or allergic asthma, where this patient's IgE level might be high or low, but specifically, they might be positive for skin prick test to a certain allergen, or there might be positivity to antigen-specific IgE in these patients. So now we come into basically a phenotype where inflammation of these airways can be eosinophilic in these patients. Obviously, the sputum eosinophil will be high, bile eosinophil will be high, and bronchial biopsy will be having increased eosinophil concentrations, and in the pheno will be usually high in certain groups, but sometimes it will not be high in certain age groups, highlighting again that asthma, even in this specific group, might be heterogeneous. And then we can have mixed eosinophilic and neutrophilic inflammation, and postgranulocytic and neutrophilic. So usually the eosinophilic pneumonias or asthmas are very sensitive to steroids, but in this subgroup of severe asthma, patients are not sometimes sensitive to oral corticosteroids, especially about one word about postgranulocytic, where there is no or minimal inflammatory cells in the airway. We now think that because of the intricate neuronal mechanisms that are there in the airway, the supply of nerves in there, because of certain substances like substances P coming into the picture, there is neuronal mechanisms that are there rather than inflammatory mechanisms that is causing airway dysfunction. And then the neutrophilic one, which is usually associated with smoking, pollutants, and respiratory infections. So we go into the endotype. So we now try to identify what is underlying, where we have T2 and T2 high and T2 low subtypes. So when we have T2 high, we have allergic or eosinophilic phenotypes, where we have increased blood eosinophils, as I previously said, and it is all driven by interleukins, the underlying cytokines that are there, that drives these pathogenic mechanism, interleukin 4, 5, and 13. And in T2 low, it is neutrophilic and postgranulocytic. It is driven by mainly interleukin 17, and postgranulocytic, you can't have any inflammation, and it is thought to be driven by neuronal mechanisms and neuronal substances that are there in the airway, and they can be mixed. So we will be concentrating on the T2 high or eosinophilic component of severe asthma, where the eosinophils, Th2 cells, mast cells, interleukin 4, 5, 13 are very important markers of these endotypes, of this endotype. So few words about these cytokines, interleukin 4 and 5. We know that interleukin 4 is a very important marker, a cytokine which primes the T cell towards a Th2 response, and the naive T cell towards a Th2 response. And then interleukin 4 further increases the class switching of the B cell to produce IgE instead of IgG and IgM. So there will be an increased amount of IgE in the patients, and they are prone to get, this is what we call allergic asthma. Interleukin 5, on the other hand, will promote eosinophilic proliferation and differentiation, and this will cause what we call eosinophilic asthma. But these are not very clear cut, because some of them have overlapping mechanism, especially about interleukin 13. It's a very important cytokine in the eosinophilic asthma group as well, because it remodels the airway and it increases the nitric oxide, fraction of exhaled nitric oxide in the breath. And that is because of it increases the inducible nitric oxide in the airway, and it is associated with remodeling and severe asthma as well. And there is another picture now. This is the typical allergic asthma or that we know, but Th2 driven pathway that we know, but now the innate lymphocyte cell which secretes TSLP, that is thymic stromal lymphopoietin, is coming into the picture. So because of the lack of time, let me go through very quickly. Earlier we thought that an allergen, when it comes to the epithelial cells, it gets into the dendritic cell and it secretes, it converts naive T cells into Th2 cells, which go into produce interleukin 4, 5, and 13. But now we know that there is another pathway, especially when there is epithelial damage due to various substances. These epithelial cells will secrete what we call alarmins, the thymic stromal lymphopoietin, interleukin 33, interleukin 25, which stimulates the innate lymphocyte cell 2, IL-2, ILC2 to stimulate or produce IL-5 and IL-13. And we know that IL-5 and IL-13 are very important, especially IL-5 contributes to the eosinophilic inflammation, and IL-13 will contribute to the airway remodeling through inducible nitric oxide pathway. So there is now, we know now why certain stimulants or certain irritants can cause a eosinophilic type of inflammation in airway rather than antigen or the allergens only. So not only allergens, but certain substances now can cause this eosinophilic inflammation. I think that is a very important thing that we have to know. About epithelial alarmins, we have 3, as I told you, and it has multiple functions. And now we have developed alarmin inhibiting substances as well. So phenotyping in real life, it is true that we have this type of asthma in our community, in severe asthma. 20% is T2 low, but 80% is T2 high asthma. And in that proportion, we can say that allergic sensitization, that these patients who are having allergic reactions and IgE specific reactions, they are having this group. And we can see that even though there are some people with only eosinophilic high group, and there is a group where pheno is only high. So this group is probably driven by interleukin 13, and this group is probably driven by interleukin 5 only, which doesn't, that explains why these separate groups exist. And hence, when we are selecting targets, we can again see this, again in this allergic or Th2 driven pathways, there is a huge diversity, and that is why some of these patients will not even respond to targeted treatment as well. So what are the targeted treatment? If we are going for IgE blocking, especially in allergic asthma where increased IgE is there, we can go for what we call omalizumab, which is an antibody against the Fc segment of the IgE molecule. Then we can go for dupilumab. This is a IL-14, IL-13, because dupilumab, interleukin 4 and 13 receptors share the same part as one of the part of the receptor, so that we can give to both, and dupilumab is one of the best drugs that we have. And then we have mepolizumab, which is IL-5 inhibitor, and at the same time we have benralizumab, which inhibits the receptor in the eosinophil, then it attaches to the IL-5 receptor and inhibits it. And then we have the tezepelumab, that is again inhibiting the alarmins that are there, now that is developing into, and it's coming into the picture now. So whatever the biologics that we give, what we are expecting is, especially in severe eosinophilic asthma, to reduce the exacerbation rate, reduce the corticosteroid use, and improve the lung function. So what is the pathway that we can go? Right, one is that depending on the eosinophil count, we can take certain decisions. So especially if the eosinophil count is low, even though we are talking about eosinophilic asthma, I thought that this is important to put this picture in to identify the new developments, because this is a group, eosinophils less than 150 is a group which we find it very difficult to treat, and they don't respond even to the biologics. So even if the eosinophil count is less than 150, if the pheno is high, then there is a place for dupilumab, that is IL-4, IL-13 inhibitors, or thymic stromal lymphopoietin, that is tezepelumab. And if the patient's pheno is low, as well as the eosinophil count is low, then dupilumab is the treatment of choice in these patients. In the discussion time, we can go into details, but I don't have much time. So pheno is less than 25 in less than 150. IgE, especially if there's an allergic component, we can go for, or else we can go into TSLP. So even in low eosinophilic severe asthmatic, less than 150, now we have a treatment option in our armamentum, that is tezepelumab, which has shown to be beneficial in certain groups of the people. So when we have consider these patients who are having eosinophils between 150 to 1,500, especially in a context of parasitic disease in Sri Lanka, allergic bronchopulmonary aspergillosis, we have to again think of why this eosinophil count is high rather than attributing it to asthma. But after that, if we are happy about it, then if these patients' BAL eosinophils and pheno levels we are taking into account, and if the blood eosinophils to pheno levels are high, we can give anti-IL-5 based therapy, or if the pheno is high in these patients, obviously we have to go for interleukin 4 and 13 dependent treatment strategy, because that will inhibit the inducible nitric oxide production, hence reduce the airway remodeling. But when we think about other things that we have to consider, especially in a patient with atopic dermatitis, and dupilumab has shown significant, that is IL-4/13, the IL-4/13 receptor blockers have shown significant efficacy in these patients who are having atopic dermatitis, not only atopic dermatitis, esophageal, eosinophilic esophagitis as well. We know that eosinophilic esophagitis is usually associated with asthma, and it is a very difficult thing to control, but now recent studies have shown atopic dermatitis, if it is coexisting, it is best to give IL-4 and IL-13 inhibitors. When the patient is having chronic rhinosinusitis with nasal polyposis, then the treatment of choice again would be IL-14 and IL-4 or anti-IgE if the IgE levels are high. And if the patient is having hypersensitivity to inhaled perineal antigen, obviously with the eosinophilia, anti-IgE, that is omalizumab, has a place in this patient. So just to highlight that, depending on these patients' clinical features, and other than that, the pheno, the eosinophilic component, as well as the underlying other comorbidities, and including steroid use as well, our treatment options will vary with various biologics, right? So specifically about steroid-dependent asthma, which is a very important aspect in a patient who is having steroid-dependent asthma, that is using steroids more than 50% of the chance. Certain biologics like anti-IL-5 and anti-IL-4/14, dupilumab, mepolizumab, as well as benralizumab has been shown to be more beneficial and allowing us to taper off the steroid dose in these patients rather than other biologics that we have. And if the patient's blood eosinophil count is more than 1,500, after excluding certain diseases that can mimic asthma, again, allergic bronchopulmonary aspergillosis, Sturge syndrome, which is now called EPGA, eosinophilic polyangiitis granulomatosis, and then other important thing is the parasitic infections and probably some drug-related eosinophilia. We had and fungal infections as well. After that, we can consider IL-5 and IL-5R alpha receptor blockers. So just within this 20 minutes, probably 22 minutes, I have tried to summarize what severe asthma is. Severe asthma is simply, first thing, we have to treat the patient in the appropriate step of the ginaglidine with the appropriate drugs, and we have to see whether this patient is adherent to the treatment properly. And if it is properly adhered and excluding other comorbidities, then we can define severe asthma. When this patient is having more than 150 eosinophils in blood, or sometimes even more than 300, or sometimes the biomarkers are positive, like pheno, periostin even, then we can think about type 2 driven asthma, but depending on the eosinophil count, we can consider them to have severe eosinophilic asthma. And then we have novel strategies now that are catered specially to a single patients. We are targeting now specific cytokine pathways to that specific patient so that there will be more improved in outcomes, especially reducing the exacerbations, reducing the steroid dose in these patients, improving outcomes of these patients and quality of life, and hopefully so that we will be able to help them have a better life. Thank you very much.
Thank you, Neranjan, for that excellent lecture. Forum is open for discussion. Any questions? Okay, Neranjan, is pheno available for us?
I think in certain laboratories, I think in Colombo, I think it is available. I'm not very sure, but the problem with pheno, and I think pheno is a very important thing, Vatsala, especially I think, as you know. Now, earlier we thought that it is an indicator of eosinophilic inflammation, and sometimes it was used to measure the response to corticosteroid as well. But some of the studies have not shown a significant correlation between the pheno as well as the treatment response, even in eosinophilic asthma. Probably because eosinophilic asthma, severe eosinophilic asthma, as we discussed, has many phenotypes or endotypes inside them. So in a patient who is having increased interleukin 13 and interleukin-4 driven asthma or eosinophilia, probably FeNO will be a good marker for response. But in patients who are probably driven by other mechanisms, because especially interleukin-13, it's a very important thing that induces it acts on the inducible nitric oxide pathway. So, but in these patients, it will be a good measure, but in certain people, it might not be a good measure. So most of these investigations and the clinical features, when we lump together, probably will give a good idea.
But maybe it's equal, isn't
Yes,
it, even
yes,
without
yeah.
FeNO? Okay. Any questions from the audience? In the absence of any questions, I'd like to thank Dr. Neranjan Dissanayake again, and we'll move to the next lecture. Okay. There's a token of appreciation for you.
Next, I would like to invite Dr. Vijai Kumar Ratnavelu, who has come all the way from India. He's a specialist respiratory physician and formerly professor of pulmonary medicine, Mediciti Institute of Medical Sciences. It's a pleasure to have you, and you'll be speaking on novel approach to COPD beyond goal guidelines. Dr. Ratnavelu.
Respected chairpersons, fellow faculty, and wonderful delegates, ladies and gentlemen. I deem it a great privilege and pleasure to be part of the 57th annual academic sessions of Ceylon College of Physicians. For this, I thank the President and the entire organizing body. I bring affectionate greetings of love from people of India. Pulmonary medicine in general and management of COPD in particular has undergone a sea change in the last 5 decades. Just to highlight, I would like to share an anecdote. 44 years ago, in 1980 precisely, I qualified as a pulmonologist. And there were no nebulizers in my city at that time. So I bought a nebulizer, Devil Base of USA make, the first ever in my city of Hyderabad. I wanted to make it popular. So I took the nebulizer to the largest government hospital in my city with 3,000 beds, along with a crew of camera people from the government TV channel. And we were there at the hospital at 12 o'clock midnight, because I thought that is when all the acute asthmas and acute exacerbation patients would be there. Sure enough, there were 20 people in the emergency room, all of them waiting to take the intravenous aminophylline injections, because that is what was available 44 years ago. When I offered the salbutamol nebulizing solution to these patients, they were not very keen. They refused, and they wanted their favorite aminophylline injections. But then one elderly gentleman who was severely breathless, he agreed. So as the 2.5 ml of bronchodilator solution was entering his lungs, in a few minutes I could see his face was beaming with happiness, and there was a big smile, which was duly captured by the TV cameras. For me, the journey of pulmonology and that of airway disease treatment took off that day. So, friends, the saga of the gold guidelines started almost in 1958 when a group of doctors, experts, sat in London and they wanted to define, classify, and put some guidelines for treatment of airway diseases. This was called the SIBA Symposium. But it took almost another 40 years for the National Heart, Lung and Blood Institute in UK and the World Health Organizations to come together and form what is known as the Global Initiative of Obstructive Lung Diseases. So before we go, what is beyond the gold guidelines of 2024, because it was published just a few months ago. So let us just spend some time in looking at what are the key changes that happened in gold guidelines of 2024. One very important change was the PRISM, the preserved ratio, but impaired spirometry. It is something similar to the heart failure with preserved ejection fraction. Normally, we diagnose COPD when we see the spirometry, where the forced expiratory volume in the first 1 second by forced vital capacity is less than 70%. But in some people, it is more than 70%, but yet they have obstructive airway disease. 30% of these PRISM patients eventually transition into an obstructive pathophysiology and an obstructive spirometry, and they become FEV1 by FVC less than 70%. Who are these people? Higher age group, current smokers, mostly females, and they have a longer forced expiratory time. If you are familiar with doing the spirometry, usually we want a 6 seconds of spirometry, but these people keep on blowing and unable to empty their lungs, and the curve goes on. So it's a very long forced expiratory time and lower baseline of FEV1 percentage and also FEV1 by FVC. The other important key change was the hyperinflation as seen by clinically and also by radiology. And they have a higher lung volume after a spontaneous expiration. And this hyperinflation is associated with increased dyspnea, increased respiratory failure, increased hospital visits and hospitalization, morbidity and mortality. Hyperinflation happens due to loss of elastic coil. Again, one more important key change was, it says, pre-bronchodilator, because spirometry is done twice. Once as soon as the patient comes, then he is given a bronchodilator solution, and then 25 minutes later, it is repeated. And if there is a big change, more than 12% in FEV1, then it is asthma, otherwise it is COPD. So if the pre-bronchodilator spirometry values are acceptable, we do not have to do the second one. And there are some patients whose spirometry shows no airways obstruction, but do watch them, especially the smokers. Another key change was about the CT scans for COPD. Now, doing an annual low-dose CT scan in the age group of 50 to 80, especially for smokers who have more than 20 pack years, is being practiced in many countries, including India. So when smokers undergo this low-dose CT scan, seize the opportunity and look for COPD. because many of these patients can have COPD because it is a common risk factor of smoking. Look at the symptoms, ask for the symptoms, and do a spirometry, and you can pick up many cases of COPD. What do you see on the CT scan? Emphysema, air trapping, air wall thickening, mucus plugging. But then you need to have a very high resolution monitor, and you need to keep scrolling slice by slice to pick up these important features. And it implies that there is a rapid decline in lung function over a period of time and worse quality of life. Dr. Neranjan very beautifully explained about the blood eosinophil count, and this is an important thing for asthma. But then when you see the blood eosinophil count, which is more than 300, acute eosinophilic count, it shows that these COPD patients, where the usual treatment is long-acting beta agonist plus a long-acting muscarinic agent, they also benefit by adding a third medicine, that is the inhaled corticosteroid. So whether or not to add inhaled corticosteroid, you will get the answer by doing a blood eosinophil count. And when we do the CT scans, many of these COPD patients also have certain changes of interstitial lung abnormalities. These patients have increased mortality. It's seen in about 5 to 10%, mostly in adults above the age of 60 years. And the GOLD Guidelines 2024 spoke written elaborately about the smoking cessation, about the different drugs available, different drugs which should not be used, and also which should be used, like bupropion and varenicline, and extensively about the nicotine replacement therapy. Vaccination, I'm sure as physicians, many of you must be doing it for your diabetes patients, chronic kidney disease patients, and heart patients. So in COPD patients, we advise a regular pneumococcal vaccine, influenza vaccine, shingles vaccine, respiratory syncytial virus, which is not available in our country, and whooping cough, because it's quite common, because many of these patients of COPD, they have little grandchildren roaming around in the house, and they bring the whooping cough bug and transfer it to their grandparents. We know that the earlier COPD guidelines, GOLD guidelines, divided the categories into A, B, C, and D, depending upon the frequency of exacerbations, depending upon the severity of the symptoms. But then eventually we realized that the C and D group, they merged together because these are the groups who have very high rates of exacerbations. So the recent guidelines clubbed them too and then created the E group. And what is important is that these people have to be handled with kid gloves because they get into exacerbations anytime. Now friends, ladies and gentlemen, we'll now move on to the novel therapies beyond the COPD GOLD guidelines of 2024 and what the future holds for us. Can we predict COPD? There is no big point in treating a patient who already has symptoms, who has all the features of COPD, and is a smoker, and we see him at the age of 50, 60, 70, and then treat him. But then can we predict COPD? So for that, we need to look at young people who are smokers, whose X-rays are normal, whose spirometry is normal. It's a very tough study. So this was done by the British Early COPD Network study, which was published just a couple of months back. It is called the Beacon study. So what they did was, it was published in Thorax. They picked up 431 current smokers, 16 pack years, age around 39, symptoms were recorded as per the COPD assessment test. Spirometry was done for all of them, and quantitative CT scan of the thorax was done. And for control, they had 67 never smokers. When they evaluated 368 subjects by following them up with spirometry every 6 months for the next 32 months, they found out that FEV1 decline correlated with the quantitative CT changes and also the COPD assessment test and also the symptoms. So the details are as follows. Just for the sake of information, COPD assessment test comprises of 8 questions scored from 0 to 5. So any patient can have a maximum of 40 and a minimum of 0 in normal people. So this is a very useful test to assess COPD. So in this study, 58% of the smokers had a COPD assessment test of more than 10. 24% reported chronic bronchitis. And the results, when they looked at the quantitative CT scans, it showed a functional small airway disease, ground glass opacities in the CT scans, and the ratio of small blood vessels to the total pulmonary blood vessels was high. And they concluded in this study that all changes were associated with faster decline of the forced expiratory volume in the first second. And these structural abnormalities are present early in the natural history of COPD and are markers of disease progression. That is how we can predict COPD in the young smokers. So to go into the details, the air trapping was more in the beacon group compared to the placebo group. Emphysema was more in the beacon group. Again, the air wall thickness was more in the beacon group compared to the normals. And you can see the CT scans, all that green on the right side is all ground glass opacities, which is more in the apices and also at the bases. And there was air trapping, there was emphysema, these are color-coded, quantitative, specialized CT films done exclusively for this study, not available as a routine for everyone, but then they are showing the way that it can be done. The ratio of the small blood vessels to the pulmonary blood vessels was higher in the beacon study. What is the significance? Why are the small vessels more? Why are they more in COPD is not yet very clear. The decline of FEV1 was 36 ml per year in the beacon group. And then everybody was excited. There were editorials. They said, oh, we got the missing piece now. And then the CT changes seen in the COPD have been studied even earlier. But then this beacon study was very unique. The second thing that I would like to share with you is that COPD exacerbations are very important because they increase the morbidity, mortality, hospital stay, cost, everything. So can we prevent exacerbations? So our research should be directed towards prevention of these COPD exacerbations. How can we do that? World Health Organization estimated that by the year 2060, we will be having close to 5.4 million deaths because of the COPD exacerbations. But in the last 4 to 5 months, single inhaler triple therapy has been introduced across the world. We use a lot. The single inhaler, that is in one inhaler, you have the long-acting beta-2 agonist, you have the long-acting muscarinic agent, and you also have the long-acting inhaled corticosteroid. So given only once a day, works for 24 hours. So it has brought down the morbidity, brought down the symptoms, brought down the exacerbations, but then still it's a long way to go. So enters humanized monoclonal antibodies. I am thankful to Dr. Neranjan for explaining about the eosinophils, IL-13, IL-4, IL-5, in what way omalizumab, benralizumab, and dupilizumab are different. So here I share a study called the Boreas trial, which was published just a few months ago in New England Journal of Medicine, where they looked at dupilumab for COPD, not for asthma, because of the high type 2 inflammation which is directed to COPD through the eosinophils. So the study design is something like this. They selected close to 1,000 patients. The blood eosinophil count was more than 300 in all these patients. That shows that they had type 2 inflammation. It was a 1-year study, phase 3, multi-center, double-blind, randomized clinical trial. So they gave dupilumab 300 milligrams subcutaneously twice a month, along with the standard treatment, what I mentioned, single inhaler triple therapy of LABA, LAMA, and ICS. It was called the Boreas trial, and the results were fantastic. Acute exacerbations came down, spirometry improved, symptoms came down, all compared to the placebo. So, borrowing the slide from Dr. Neranjan, you can see in the center, the dupilumab is able to effectively control the eosinophils because it is directing its action toward the STAT6 through the Janus interleukin. So IL-4, IL-13 are the most important for the eosinophilic inflammation. So this dupilumab is able to control that. Benralizumab, mepolizumab failed because they were directing the IL-5, not IL-13 and IL-4. So in this trial, we could see the placebos. Compared to the placebos, dupi was very good in bringing down the exacerbations, and severe exacerbations were much less, and FEV1 improved, and new biologics are around the corner, which are twice in a year, very convenient to give. And of course, everybody was excited. They said, finally, the biologics in COPD are here. Atrial fibrillation are very common in COPD, and COPD is very common in people who have atrial fibrillation. So we have to keep our antennas very high and then keep looking for atrial fibrillation in our COPD patients, and also vice versa. Different pathophysiological mechanisms, but of course there are comorbid conditions like sleep apnea, heart failure, hypertension, and obesity. And the recent European Respiratory Journal gave some guidelines, and they said, be careful when you are using bronchodilator like beta-2 agonists, both short and long acting, theophylline and oral steroids. But it is okay to give short acting muscarinic agents and long acting muscarinic agents, inhaled steroids, macrolides, and roflumilast. A very simple table fan surprisingly gives a lot of relief to these COPD patients for their reduction in their subjective feeling of the dyspnea. So whenever you have given all the drugs and still the patient is breathless, try the table fan. In the last 2 minutes, I will take permission from the chair. I want to discuss about 2 things. Medical drones have come a big way in transporting medical supplies to the distant areas. So in India, during the COVID times, when there were cyclones, when the railway tracks were not there, roads were not there, the vaccines were transported through the drones to the remote areas, especially in the northeastern states. And one drone took off and traveled 31 kilometers in 15 minutes non-stop and gave the vaccines. I don't see any reason why we can't do it here in Sri Lanka, Colombo to Negombo, 35 kilometers in 20 minutes non-stop to supply anything. So for COPD, probably we can send supplies of BiPAP machine, intravenous antibiotics, intravenous steroids, nebulizer solution through the drones. Lastly, in 1 minute, this is the app which I have developed for patients who are having chronic lung disease, especially COPD and ILD. It is called Pulmo at Home, where the pulmonologist will come to the patient's house, not in the first visit, but for the review visits. So especially ideal for patients who are very senior, elderly, wheelchair bound, on oxygen, on NIV, they can't come. The children are already employed, having a family, they can't accompany. So here the doctor goes, how does it work? I developed it for the city of Hyderabad, which is 680 square kilometers. 30 senior pulmonologists are available, and we have 500 young pulmonologists, and it acts very similar to the Uber cabs as an aggregator, and any young pulmonologist can cover about 5 kilometers radius. The patient has to ask for a pulmonologist visit, very simple. Need a pulmonologist consultation at home, date, time, and the pulmonologist is there. So it can be extended to other things like heart failure, connective tissue disorders, diabetes, and hypertension as well. My last slide, a quote from Voltaire, who said, "The present is pregnant with future." Thank you very much.
Thank you very much, Dr. Ratnavelu, for that very interesting and illuminating talk on COPD. Any questions from the audience?
Hello, good afternoon. I think we met in the hotel lobby yesterday. Thank you very much for a comprehensive review of COPD. I am a nephrologist, but I say that many of my patients have got COPD. So we need to also unearth COPD, which is stilled or whatever, because sometimes patients come to us before they come to you. My question is that at least in the West, particularly in the young population, cigarette smoking is not that common, but they are now going into e-cigarettes and vaping, which is now become an epidemic among the young generation. From cardiovascular and renal point of view, we have done some work where we know that this vaping still causes vascular dysfunction, altered cardiac remodeling, and also reduces the blood flow through the kidneys. They're short term. Have you got anything or angle that we may replace the cigarettes in future with these e-cigarettes, and that still will pose a huge problem in, say, year 2060 with a new evil, which will be the e-cigarettes? Is that been incorporated in your guidelines?
Thank you, sir, for the nice question. We had editorials and we have some publications in the New England Journal of Medicine, which says e-cigarettes, that is vaping, is as bad as the regular cigarettes. And unfortunately, e-cigarettes also contain nicotine, which is habit forming, and they have a lot of other chemicals because they come in different perfumes and different sizes and shapes. So it is as damaging to the lungs as the regular cigarettes. So I think we have to find a way, some policy where e-cigarettes have to be banned. In India, it is banned actually.
The second question for you is that low dose CT annual for smokers, very much in or the future. You know, the future is more important. That what we are doing today possibly would be becoming the therapies of the future. So the one exciting thing which we are doing in UK is to bring back the first MRI, which was 0.5 Tesla magnet, which is now being converted into a held hand probe. Like ultrasound, you can just have that held hand probe. And I must say that compared to the X-rays, and I've seen few of the chest MRIs, which are as good. Do you think that that should become the norm to even avoid the radiation hazard for a person who is already high risk for cancer?
That looks like a great news. But anyway, the radiologists have calculated the radiation risk which comes from a chest X-ray, which comes from a regular CT scan, which comes from a high resolution CT scan, and also the low dose CT scan. And they decided it is something like getting exposed to the tropical sun for 14 days. So not a great amount of radiation. MRI sounds very good, but MRI is not a very good tool for the lungs. It is good enough for the bones and the blood vessels, but not so good enough for the lungs because it contains air, and MRI doesn't really give us the details. And then, of course, logistics of having an MRI as a screening tool, they exist. But anyway, it's a very nice information that you have given. Thank you.
That you could quite easily use an inhaled xenon or something like that and then take an MRI, which might possibly improve the detection of air wall thickenings or air trappings, very early interstitial fibrosis changes. So I think what I'm just trying to say to the audience that future is very bright.
Yes.
And
yes.
I say to my trainees in United Kingdom that future, what we do today, and
Correct.
when in say 20 years time, the trainees today, when they look back at what you and me have been doing,
Correct.
they will laugh.
Yes.
It is like when we talk to them that we had to walk
Yeah.
1 mile to find a telephone booth.
Yes.
They don't believe it, that we have lived those times.
Yes.
Medicine is going to be like this. It would be, believe me, I can't tell you how exciting the future is, but sad thing is that I won't be alive to see it. It is you guys who will benefit from it.
Yeah.
I'm certain that the medicine will be completely different from what you and me have been practicing.
Yeah. In fact, 30 years ago, when my patients asked, "Sir, the report says my eosinophils are very high," I just dismissed it off, saying that they will be high in allergy, don't worry about it. But now we have so much of science behind the high allergy. So the reply which I gave 30 years ago is totally untrue. Thank you very much for all that information. Thank you.
Thank you, Dr. Ratnavelu. But just one comment, I think with taking the social discrepancies that happen in our part of the world, and now COPD being so common with, in the non-smoking COPD becoming more common, I think access to very high-tech investigations and even medicines would be very difficult. So there's a long way to go, especially in our part of the world. I think we have a long way to go to help these people to have a good life with the minimal resources that we have, isn't it?
Yes, sir. Yes. So preventing people from smoking would go a long way rather than trying to spend a lot of money in trying to detect COPD at an early stage or treat them with very expensive monoclonal antibodies or
I think
biologics.
indoor air pollution is also plays a big role in our part of the world. Right. Thank you. With that last comment, I think we shall conclude this.
Thank you.
This session. Thank you very much. And on behalf of the CCP,
Thank you.
may I present the certificate of appreciation to you.